Now what we're going to talk about is orthopedics. So when it comes to orthopedics, there's actually quite a bit of things you need to know. You need to know everything about wrist injuries, shoulder injuries, hip and thigh injuries, knee injuries, and ankle injuries. Luckily, although there is quite a bit of information, it's fairly straightforward, fairly easy to memorize, and treatments are fairly similar in nature. So let's go through each one of these areas, and we'll talk about all the high-yield pathologies that we need to know. So first, let's talk about types of fractures. Okay, there's many types of fractures. We have open fractures, closed fractures, compression fractures. An open fracture is what we also call a compound fracture. Okay, that means that the wound is communicating with that fracture. Okay, so we expose bone to the air, and thus contamination is possible. So obviously, if we take bone, which is in the body, and we expose it to the air, we carry a high risk of infection. Okay, so anytime there's an open fracture, then we're going to, aside from management, also want to give antibiotics. Closed fractures are also known as simple fractures. That means the skin over top of the bone remains intact. Whereas if we're talking about an open fracture, you can expect to see some bone sticking out. A compression fracture, think about a compression fracture as a form of crushing. So if the bone is like this, instead of a force coming at it this way, think about the force coming at it that way, pushing down on it and compressing the bone in this manner. Okay, we also have a complete fracture. Now that's when a fracture separates completely. So if we're looking at a bone and it separates completely, we call that a complete fracture. An incomplete fracture are when we have bone fragments that remain partially joined. So the break doesn't completely cross the width of the bone. So if you can imagine, it might look something like this. Okay, so we have a break here, but it doesn't go all across the bone. Sorry, my artistic skills are not that great. Linear fractures, fractures parallel to the bone's long axis, which means a fracture in that fashion. And a transverse fracture is one that goes at the right angle to the bone's long axis. So if we look at our bone this way, that would be a fracture in this direction. An oblique fracture is a fracture that is diagonal to the bone's long axis. So something like that. Spiral fractures are when there's at least one part of the bone that is twisted. So this is hard to draw, but imagine if we have a bone that is broken and there's sort of a twisting of it. If you can imagine, that's what we call a spiral fracture. Comminuted fracture is when a fracture in the bone has broken in several places. So if we look at this, it kind of looks really sloppy like that. There's many different breaks on that bone. And an impacted fracture is when a fracture where bone fragments are driven into each other. So if you can imagine, we have a break in this fashion, and parts of that bone perhaps are driven into the other parts. So very traumatic type of injury. Okay, so those are the types of fractures that you want to know about. Now let's talk about wrist injuries. So some of the common high-yield wrist injuries are fractures, which we have a distal radial fracture, a scaphoid fracture, and then carpal tunnel syndrome, which is not a fracture, but it is a compression of the median nerve within that carpal tunnel. So let's get into each one of these. So the distal radial fracture is also known as Cole's fracture. Okay, this occurs after someone falls onto an outstretched hand. So if someone is falling down and their hand is outstretched in this fashion, okay, that results in a Cole's fracture. Now, a Smith's fracture, on the other hand, would be if someone falls down onto a flexed hand. So if they're falling in that direction and we hit the concrete like that, that results in a Smith fracture. Okay? And you can just see in this image here, we've got our radial head fracture right here. Okay, ulnar fractures. Ulnar fractures are going to occur most commonly when there's a direct blow to the arm. So think about sports like football, hockey, rugby, karate, when there's a potential to directly blow at the lateral aspect of the arm. So if someone was to put their arm up and take a severe hit to that arm, okay, that's going to result in an ulnar fracture. So we have our radial side here, we have our ulnar side here. Someone was to hit that aspect of the arm, okay, that would result in an ulnar fracture. So how do we diagnose this? All fractures are going to require an x-ray. Very simple strategy to make a diagnosis. Okay, now for radial and ulnar fractures, we're going to immobilize with a cast for 2 to 4 weeks, followed by bracing. So 2 to 4 weeks, okay, followed by bracing. Now a scaphoid fracture, okay, occur most commonly as a result of a fall. Now this is commonly misdiagnosed as a wrist sprain because oftentimes the pain isn't super severe to the point where someone thinks they have a fracture. Now diagnosis is simple. We have an anatomical snuff box, which is that aspect just at the base of your thumb. Okay, so you put direct pressure on that snuff box or direct palpation, and pain will be elicited within that snuff box. Now we can make a definitive diagnosis with an x-ray. Oftentimes this though will be a big indicator. So how do we manage this? Patient goes into a thumb splint for 10 weeks. Okay, we do it longer because we're worried about avascular necrosis of the scaphoid bone, which means death because it doesn't get enough blood supply. So it's not very easy to see, but here's your scaphoid bone, and then here's that fracture right there. Now carpal tunnel syndrome. So commonly carpal tunnel syndrome occurs in people who do repetitive things, people who are typing a lot. So this can even happen in, it used to happen more so in people who typed for a living, like stenographers or secretaries, but now because almost everybody uses a computer all day, every day, it's seen more common in your everyday person. Okay, so sitting at a computer is a very important diagnostic factor. Someone who, for example, never uses a computer has a much slimmer chance of developing carpal tunnel syndrome. So here's a look at some of the structures of the hand. So here we see some of the bones, scaphoid lunate, the triquetrum, and the pisiform here. Now here we are in our carpal tunnel. Now we have a lot of flexor tendons, right? These are all going to attach to the fingers, and if you remember, the median nerve supplies the thumb, the first two fingers, and the lateral the lateral aspect of the ring finger. So repetitive use and inflammation will send pain signals down into all of these nerves which supply those aspects of the hand. Okay. So what do patients experience? Obviously they experience pain. One of the big things is numbness. And don't forget that the distribution of the median nerve. Okay. Tingling of the fingers that the median nerve supplies is also very common. Okay. And as I mentioned, patients who work at a computer all day are most likely to experience this problem. So as we mentioned earlier, the thumb, the index, the middle, and then the medial aspect of the ring finger will be affected. Okay. So how do we make a diagnosis of carpal tunnel syndrome? 2 tests we can do right in the clinic. Tinel's sign is pathognomonic. All you do is you tap on the palmar aspect of the wrist, and this should reproduce the shooting pain or tingling sensation in the fingers. And what that where we're going to tap is going to be right around this area, because what's right there? That median nerve. So you tap on that. Okay, that's Tinel's test and Tinel's sign if it elicits pain. The other one is Phelan's test. So this is also a strong indicator of carpal tunnel syndrome. So you take both of the patient's hands, and what you're going to do is you're going to place them at 90-degree angle to each other. So here's the arms, here's the wrist, here's the fingers, okay? And we're going to have them hold that for 30 to 60 seconds. And if this does reproduce the same findings, the same pain, then that's a positive Phelan's test. So what is the management for carpal tunnel syndrome? The first thing we do is we tell our patient to avoid any aggravating activity. Most people can't do that because it's job related. So wrist splinting is one of the things that we're going to do. Now, they're not just going to ask you about that. They're going to ask you about what angle we keep those wrist splints in, and we're going to keep them in slight extension. So we're going to keep that wrist in slight extension. Okay. So here's the dorsum of the arm. Here's the anterior aspect of the arm. We're going to keep this slight extension, and that should take some of the pressure off of the carpal tunnel. Now, if splints don't work after a while, a steroid injection right into that carpal tunnel can help with the pain. So what we'll do is we will take a needle and we'll inject it right into this carpal tunnel, hopefully alleviate the inflammation and help our patient with their pain. Now, a last resort, okay, if none of this works, if the conservative measures don't work and the steroids don't work, then we can do a surgical procedure which will alleviate the pressure, but unfortunately we go in there, so it's surgery, so there is quite some time to recover. It might not always be ideal for patients. Shoulder injuries. So before we get into the shoulder injuries, let's just go over the injuries or the muscles of the rotator cuff. So don't forget, we have the sits muscles. We have the supraspinatus, which is the first S, the infraspinatus, which is right here. So supraspinatus is up here, okay, right here as well. So supraspinatus, infraspinatus, teres minor, which is down here, attached to the humeral head, and then the S here stands for subscapularis. So this is the posterior view, right here. This here is the anterior view. So this subscapularis is actually on the anterior portion of the body, and it's behind the pecs. So, rotator cuff injuries. What are some of the signs and symptoms? Pain and tenderness at the deltoid and over the anterior humeral head, because a lot of these muscles attach to the anterior humeral head. So that's where you're going to feel a lot of pain. Okay? Patients have decreased ability to rotate the arm internally, and often you can feel crepitations over the humeral head. There's also the presence of something we call near sign. That's pain with the attempt of forcible forward flexion of the arm. So people who lift weights, people who play sports, people who do anything that's physical are going to notice the pain when they have a rotator cuff injury, because you can almost never do something physical without using these muscles. So how do we diagnose this? It's basically a clinical diagnosis. Okay, the history of overuse of perhaps the rotator cuff, and all of these symptoms that we just discussed are all things you're going to see. Now, if we really need an immediate diagnosis, an MRI can be done, but for your typical patient, that is not going to be the case. So how do we manage a patient with a rotator cuff injury? There's some rotator cuff specific exercises that are excellent. Okay, now consult any orthopedic book in order to see these exercises. They're very simple, straightforward. NSAIDs, rest is also something, just rest that rotator cuff. Okay, very helpful. Steroid injections can help if conservative measures fail and you don't want to undergo surgery. Last resort, something for example pro athletes, would be arthroscopic surgery. Shoulder dislocations. Okay, so a dislocation occurs when the humeral head is displaced from the glenoid fossa. Okay. Now, subluxation is not the same thing. It's just a translation of that humeral head within that glenoid fossa, not an actual removal of it completely. So we have anterior dislocations and posterior dislocations. Now, anterior dislocations occur 95% of the time, most common type. Okay, and we call that a subcoracoid dislocation. How does that occur? Direct trauma. So someone who gets tackled in football would be a very common example. Someone who plays rugby or hockey. These are all common scenarios when an anterior shoulder dislocation occurs. And what are some signs and symptoms? Severe pain, obviously, and immobility of the joint. The arm usually just hangs to the side. Okay, you won't be able to move it. That's a telltale sign that it's not in its socket. Now, confirmation can be done with an x-ray, and when we do an x-ray, what we're really looking for is axillary nerve damage. Okay? We always want to assess, is there nerve damage, is there not nerve damage? Very important, because if there is, then we have to call a neurosurgeon and a neurologist in order to do some more in-depth procedures. Okay? So you also want to look for signs of rotator cuff injury whenever we have a patient with an anterior shoulder dislocation. Okay, so here's an x-ray. Now what we're looking at here is, you can see the glenoid fossa is right here and the humeral head is completely dislocated in an anterior fashion, so it's moved forward. Right? That's your anterior shoulder dislocation. Posterior shoulder dislocations happen in two situations. A patient has had a grand mal seizure, or a patient has been struck by lightning. Those are the only two scenarios where you're going to see posterior shoulder dislocation. Signs and symptoms are the same as the anterior dislocation: immobility and pain. Diagnosis, again, we do an x-ray. Okay? And here, what you can see is, normally the anterior dislocation would result in a humerus sitting about here, but in this situation it's back posterior. And you can see that some of these structures, some of these bony structures are actually sitting anterior to that humerus. So it's an easy way to kind of tell what's going on. Okay, so what's the management? It's the same for both anterior and posterior. Reduction of the dislocation by traction and countertraction. That helps to get it back into the socket. Okay. Second, ensure the patient avoids physical activity. At least 2 to 6 weeks should be taken off from anything. Now, if they're younger, they're more susceptible to severe permanent injury, so it should be even longer, minimum 8 weeks and more. And then finally, patients should go to rehab, because we want to ensure that they are regaining functional use in an appropriate manner. Okay, next up is hip and thigh injuries. So what do we need to know about hip and thigh injuries is that we have dislocations and we have fractures. So a hip dislocation requires significant amounts of trauma in order to happen. Okay, now most commonly they dislocate posteriorly, which is the exact opposite of the shoulder, right? So how does the hip look? It's going to look shortened and leg is rotated medially. So if we have a patient, and here is their torso, the leg looks shortened and internally rotated. Okay. Now what's the most worrisome complication? It's sciatic nerve compression or damage. So we want to do a thorough neurological exam. Make sure that they have appropriate sensation to light touch, crude touch, pinprick, etc. Okay, so there's a very classic looking x-ray. You can just see that the head of the femur is absolutely completely dislocated from that acetabulum. Okay, now like I said, if there's concern about sciatic nerve damage, get an MRI, and then when we call neuro, they'll be able to look at that in a better fashion. Okay, so management of a dislocation. This is an emergency situation. Remember, we said that sciatic nerve damage is a severe consequence. Now we have to sedate that patient, and it requires urgent reduction. We have to get it back in that socket. Now we sedate them because it's very traumatic to put one of these back into the socket. And I remember a situation when we had a patient who was allergic to the anesthetics, so we gave him an epidural, and we did this while he was wide awake, and it was not a pretty situation. So just remember, keep them sedated if at all possible. Okay, what's the most worrisome concern? Avascular necrosis, just like that scaphoid fracture. That's why, on top of sciatic nerve damage, this is also an emergency. Okay, now if it's a severe dislocation, if they were in, for example, a major car accident, it may require open reduction. We might have to cut them open and do this in an open fashion as opposed to just traction and counter traction. So post-op management, avoid all weight-bearing activity for 3-week minimum. Then we slowly get them back onto activity with light walking for 3 to 4 weeks, and then as they get stronger, they can progress slowly. Okay. Follow-up imaging every 3 to 6 months for at least 2 years. That's the severity of this type of dislocation. Okay, that we have to follow up with them every 3 to 6 months for 2 years. Okay, very important. Now, fracture of the femoral neck. Okay, because the leg bone is so thick, this also requires a significant amount of force in order to break it. Okay, so what are we going to see? Patient has severe hip and groin pain upon movement. Well, that's not really a surprise. Okay. Now, in this situation, leg is usually in an externally rotated position. Okay, so dislocation is internally rotated, broken femoral neck externally rotated. Diagnosed with an X-ray and clinical findings. And management, orthopedic surgery. So if we have a vignette where they asked us the next step after an X-ray, it would be an orthopedic surgery consult. Okay, and what they're going to do is perform an open reduction with internal fixation. So they're going to have to get in there and really do some hardcore work to get this thing fixed. So pinning is going to be used. We're going to undergo anesthesia, etc. It's going to be a very big process. Okay, and you can see the fracture of the femoral neck, what we're seeing right about here and right over here. Okay, knee injuries, really high yield stuff, because even if you're a family doctor, internist, you're going to see tons of knee injuries because they're so common. So we have ACL injuries, anterior cruciate ligament, PCL injuries, posterior cruciate ligament, your collateral ligaments, which are on the lateral and medial aspects, and meniscal tears, which are little discs that sit in between your tibia and your femur. Okay, so let's take a look. So remember, when we're talking about anatomy of the ACL and the PCL, the anterior cruciate ligament is attached to the anterior portion of the tibia, while the posterior cruciate ligament attaches to the posterior aspect of that tibia, and that's where we get the names for these. Okay, the lateral collateral ligament, you can see, connects the fibula to the femur, and the medial collateral connects the femur to the tibia. Okay, so here's our patella. We also have our menisci, right? We have our medial and our lateral menisci, which are like little discs that sit in between both bones. Okay, and here's a more realistic look at that. So the ACL. Okay, a tear of the ACL is a common injury. Okay, so we said the ACL attaches the anterior aspect of the femur, okay, attaches to the anterior aspect of the tibia. That's a mistake, to the tibia, okay, and the posterior aspect of the femur. Stabilizes the knee during extension when the surrounding muscles are relaxed. Okay, the ACL, tears to the ACL are a common orthopedic problem. Now remember, the ACL attaches to the anterior aspect of the tibia, stabilizes the knee during extension when the surrounding muscles are relaxed. So what's the classic presentation of an ACL tear? Patient will say they heard a popping sound. Okay, as soon as the injury occurs, you'll see significant swelling, and the patient will say there's a feeling of instability, which you will also be able to feel when you do the exam. Okay, so signs and symptoms, pain, can range from mild to severe depending on the degree of the tear. Now this is most commonly seen in athletes because you commonly tear it during athletic events. Okay, so if a patient injures their ACL and continues to use it, it can lead to severe problems down the road. So make sure they get off their feet. So common causes for ACL tearing while playing sports. Okay, rapid deceleration followed by an acute change in direction. So think about a football running back. Being stiff-legged while landing. Think about a gymnast. Females who play sports with those movement patterns are more likely than males to injure their ACL. The reason for this is because of a decrease in female musculature in the legs. Okay? Females just naturally have less muscle tone than males. They might have more muscle mass in the legs, but the tone is less, and that's a big reason why we see these injuries. Okay, now the most common cause of an injury is when an athlete lands flatly on their foot. Okay, so that is 3 situations you need to be aware of that can lead to a tear of the ACL. Now, how do we diagnose this? The anterior drawer test, okay, everyone knows this. We keep the leg at 90 degrees. We pull forward on the lower leg, and if we have instability in that lower leg moves forward, that's a positive anterior drawer test. The definitive diagnosis is an MRI, and you'll actually be able to visualize that tearing of that ligament from that tibia. So how do we manage this? Oftentimes, a minor injury can be treated conservatively with rest, ice, elevation, therapy, and the use of a knee brace. Severe injuries are usually going to require surgery to reattach that ligament. Okay, the reason why is because ligaments don't have a very rich vascular supply. So if it's minor, we can let this minor blood supply take care of it. But if it's a major injury, the blood supply isn't going to be adequate and it's going to heal very poorly. So surgery is your best bet to simply reattach that ligament to that tibia. Okay, what if we don't intervene and we just let it heal? Okay, cartilage damage is very possible because tibia and femur will rub together without any protection. All right, well, now we have phases after an ACL tear. These are rehabilitation phases. So phase 1 is what we call early rehab. Okay, short-term pain relief, we use rest, ice, and elevation. Phase 2 is a 3 to 4 week period after the injury. Now we're going to use a brace on our patient's knee. Patients allowed only minimal walking, a little bit of stationary bike riding. The goal is to get the patient to be able to bend that knee to 100 degrees. Phase 3 is what we call controlled ambulation. This is a period from 4 to 6 weeks where we increase the exercise intensity and the challenge, with the goal being to get that flexion to 130 degrees and to improve their balance. Phase 4 is from weeks 6 to 8. We're going to increase workout resistance with little support. So we might have them in the gym without their knee brace on. Phase 5 is light activity from weeks 8 to 10. And the goal here is to strengthen the supporting muscles, which further help to strengthen the structure in general and improve the patient's balance. Now, phase 6 is from weeks 10 and on, with the goal being to return to normal physical activity. So they can undertake jogging, athletic drills with moderate intensity. It's important that they work up to their full speed. Okay. Now, after they've completed phase 6 and they're comfortable, then they can return to their regular physical activity. Okay, so that's just a look at common type of injury that can lead to a tear of the posterior collateral ligament. So, the posterior cruciate ligament. So what happens when someone tears their PCL? They fall on a flexed knee. Just as you see in this picture, this patient is falling on his knee, which you can see is flexed, forced flexed due to a football tackle, right? So you see this also commonly as a result of a dashboard injury during a motor vehicle accident. So what that means is, let's say you have someone sitting here in the front seat of a car and the dashboard's over here. If they get into a motor vehicle accident or there's severe, they're going fast and they stop abruptly, this person's going to fly forward, they're going to hit their knees on that dashboard, and that's going to drive the lower leg back forcefully, and that's going to lead to a tear of the PCL. Okay, so diagnosis is based on history and x-ray. We want to rule out a fracture. Now, we can do an MRI to see the ligaments better and help us determine the extent of the injury to see whether or not it needs and warrants surgery. Okay, and the management is just going to be similar to ACL, conservative if mild, surgical if severe. Okay, the collateral ligaments. So our collateral ligaments are on the medial and lateral aspect of the knee, right? So the medial collateral ligament, MCL, is most commonly injured of both collateral ligaments. The lateral collateral, or the LCL, is the least commonly injured. Obviously, there's only two. These are caused by a direct blow to either side of the knee. Okay, so the MCL is going to be caused by a direct blow to the lateral aspect. So if this is the medial aspect and this is the lateral aspect, let's say here's our medial collateral ligament and here's our lateral collateral ligament, a blow from this side will injure the medial collateral, while a blow to the medial side will injure the lateral collateral. Now you can see why it's more common to injure the medial collateral, because it's a lot harder to give someone a forceful direct blow to the knee from the medial side of their leg. Okay. Now oftentimes we see a co-injury with the ACL or the PCL. Okay, so the MCL plus the ACL and or PCL. Okay, now we call that the unhappy triad if we get all three of them. So the unhappy triad, look at this image. So we're getting forceful tackling to the knee from the lateral aspect. That's going to injure the MCL, which is sitting over here. That might also injure the ACL, and we can injure the medial meniscus. Okay, usually resulting from a football tackle to the lateral aspect of the knee. So you can imagine it's a lot harder to injure that aspect of the knee because this leg will be in the way. So management of collateral ligament tears depends specifically on the severity. Now if the tear is only the medial collateral ligament, usually patients wear one of those hinge braces over top their knee. That gives them support while it heals. Now if there's more than one ligament injured, okay, so if we have the unhappy triad, the MCL, the ACL, and a menisci, usually surgery is warranted, because if we have all of those things injured, it's going to take almost forever for this thing to heal. Now meniscal tears. Meniscal tears are most commonly in trauma and older people who have joint degeneration, and they're more commonly seen in males. Okay. Now whenever you hear that someone has torn cartilage, that's a meniscal tear, because remember, menisci sit between the bone and the medial and lateral aspects, and they act as sort of a cushion and support. Now how it happens, a patient plants their foot in the ground, and then there's a twisting motion to the knee. So the leg is planted firmly in the ground, and then they twist the knee in one direction or the other. That's going to lead to meniscal tear. So signs and symptoms: swelling plus pain on presentation. Now oftentimes the patient will complain of a clicking or a locking of the knee. So they might just be going about their day, and all of a sudden it catches or locks, and they can't extend their leg. Okay? So in situations that are very severe, surgery is obviously warranted, but usually all that's required is conservative management. Neurosurgery. Now keep in mind, a lot of the stuff we talked about in neurosurgery we talked about earlier on, and we also discussed in neurology section in internal medicine. So for example, head injuries like an epidural hematoma, subdural hematoma, subarachnoid hemorrhage, these are all things we've already discussed. So we're just going to talk about facial fractures and basilar skull fractures. Two things you're probably going to get questions on. If I'd have to guess on one thing, it would be basilar skull fractures. So the most common seen facial fractures involve the maxillary bones, okay, and then the surrounding structures. Okay, this type of break is known as a Lefort fracture. So it can involve just the maxillary bone, can also involve the nasal region and all the way up into the eye region. It can also involve the pterygoid region over here, this part that helps bring up and down or elevates and suppresses the maxillary bone. Okay, so how is this going to be managed? Surgical repair is the only thing we can do. It's just like any other break. We either have to cast it or surgically repair it. Now, because the fragility of these bones, usually surgical repair and stabilization will be required. Now, a basilar skull fracture is from an injury to the base of the skull. So we're looking at the posterior aspect of a skull. Okay, the base of the skull would be here. So if this is the nose, this is the superior aspect, this is the back, this would be the base. Okay, so there's a few classic signs. There's battle sign, there are raccoon eyes, there's hemotympanum, and there's CSF rhinorrhea. So battle sign is a bruising behind the ear on the mastoid bone. Right? This is right in line with the posterior auricular artery, and that's why that happens. The posterior auricular artery. Posterior, back here, auricular ear artery. And that's why you get battle sign. Periorbital ecchymosis means around the eyes, raccoon eyes. Now this is indicative of an orbital fracture, right? Fracture of that orbital bone. Hemotympanum, when we look into the ear, we're going to see blood behind the tympanic membrane. And CSF rhinorrhea is CSF leaking from the nose. So that presents as a clear fluid leaking out of the nose. That indicates that we have a fracture of that nasal region. Okay, very important that we recognize clear fluid leaking from our patient's nose. So here's some pictures. Here's battle sign. Posterior auricular artery has been damaged. Here's hemotympanum. So this is the ear canal that we are looking in. Okay, and this should be clear, but instead it's dark. What we're seeing is hemotympanum. And then periorbital ecchymosis due to fracture of the orbital bones. Okay, raccoon eyes is what they're known as. Now this patient is bleeding from the nose, but if this was a clear fluid bleeding from his nose, that would be a sign of CSF rhinorrhea. So diagnosing this, clinical signs are almost all we need. Okay, that usually gives it away. We always want to do an x-ray just to make a definitive diagnosis so that we can actually visualize those fractures. Now how do we treat this? Everything that is going on wrong, we have to support it. So we want to make sure we keep an eye on any excessive bleeding. Usually it'll all resorb and it'll heal itself, but we want to keep an eye on this. Now CSF, if that's leaking, we have to be careful to not allow too much of that to leak out.